Well, good day to everybody. Thank you for coming. I hope you're having a great conference. How many people here are surgeons? Raise your hand. Perfect. How many people have experience with Prodisc? How many people have experience with Prodisc? You do? Yeah, good. Well, sorry I don't speak Spanish. My beautiful wife does, but I do not. So this is going to be in English. So first of all, I want to make a plug for the crossfire that is going to occur at 1 o'clock in Salon Cielo, I think, at 1 o'clock. Dr. Ramirez from Mexico and I will be arguing about fusion versus artificial disc replacement. And I can tell you, I've been collaborating with him for a couple of weeks, and it's going to be a lot of fun. It's going to be very entertaining. Something that I will cover in my talk later on, but I will also cover here today, is what is my algorithm for treatment of patients. And my algorithm is, first and foremost, someone is a non-operative candidate until they prove otherwise. And we're very serious about that. We did a 10-year look back at my practice. And in the United States, if you cross the threshold of a surgeon's door, 1 in 5 get surgery. In my practice, 1 in 13 get surgery. And so we're very serious about non-operative treatment, and I will use anything, physical therapy, injections, biofeedback, massage, I mean, whatever it takes to get acupuncture, whatever it takes to keep people out of the operating room. And so we're very serious about that. So everyone is a non-operative candidate until they prove otherwise. Secondarily, someone is a motion preservation candidate until they prove otherwise. So a laminectomy is motion preservation, a microdiscectomy is motion preservation, and artificial disc for those patients that have a significant component of back pain, that's a motion preservation surgery as well. Next is someone is an anterior candidate till they prove otherwise, or lateral, because anterior and lateral surgeries are less morbid than posterior cervical or posterior lumbar. And then lastly, someone is a posterior candidate. Now, I am classically trained as a deformity surgeon, and so I do, my mentor in my fellowship was Dr. Courtney Brown, that some of you may know. He was the president of the Scoliosis Research Society, and so I've been trained classically as a deformity surgeon. But in Flagstaff, where I live, it is a very young, outdoorsy, educated demographic. And so artificial disc replacements work very well in that population. And so artificial disc replacements have become a huge part of my practice. I've been in practice for 18 years, ortho spine. And I know we probably have some neurosurgeons here as well. And so this, if you follow my algorithm, this is very high on my list of things to do. Again, it would be patients that would have a significant component of back pain, patients that have failed 1 or even 2 microdiscectomies. So they had a disc herniation, they got treated for leg pain with microdiscectomy. The disc collapsed some because the disc material was lost. And then they get another disc herniation, and maybe I do a revision microdiscectomy, or if they have a significant component of back pain at that time, we go to an artificial disc replacement. Certainly by the 3rd time that they lose disc material, we're going to go to an artificial disc replacement. I can tell you that I am still in the military in the United States. It is part-time, but part-time means 140 days a year for me. And so I have a lot of military patients that I treat with artificial disc replacements. I am what's called a flight surgeon, so I'm the team doctor for a bunch of fighter pilots. And I can tell you that I have more than 15 patients that I've done lumbar disc arthroplasty on that are flying fighter aircraft. And that's 9 Gs of force in this direction on the spine. And they've all done very, very well. And so we're using this even in the what's called the tactical aviation environment. A lot of first responders, firefighters, policemen, things like this. So it's a very excellent operation for those patients that have occupations that are very demanding, and Prodisc lumbar is by far and away my favorite device that I use. So if you're not familiar with the device itself, this is it here that is on an insertion handle, and it has two end plates. It has a keel that provides the primary fixation in the bone after you make the keel cut, and it's molybdenum chrome or cobalt chrome, and it has a secondary fixation apparatus, which is a titanium plasma spray coating on it that has just the right pore size for fingerlings of bone to grow down into these little crevasses to provide the secondary fixation, which is really quite solid at about 3 months. We have, in orthopedics, 80 years or so of experience of how do you fix metal to bone solidly, and the Prodisc has benefited from that experience with artificial hips and knees. At the Crossfire that I mentioned earlier, Dr. Thierry Marnet will be there. He's from Montpellier, France. He's a friend of mine. He is the inventor of the modern artificial disc replacement. Oh, here he is. I didn't know you were here, brother. So good to see you. You say hi to Lupe? Yeah. So Thierry is visionary. I like to say he is the priest and I'm his disciple. But Thierry invented the Prodisc lumbar. It looked the original design was a little different than this. He implanted 93 discs in 64 patients from 1990 to 1993. And then to his enduring credit, even though everything was working out fine, he stopped. And he said he wanted his patients to incubate. And he did not do another artificial disc until 1999. And he followed them and he's done, tens of thousands of artificial discs. You over 10,000? Something like that, yeah. And he is brilliant, and he will be at the Crossfire today as well. But we stand on the shoulders of giants. So the artificial disc, as I was mentioning, has the primary and the secondary fixation. And in this tray that you can see here goes an insert that is ultra-high molecular weight polyethylene. And it ends up being the same articulation of cobalt chrome on ultra-high molecular weight polyethylene that we use in modern artificial hips and knees. And we have a lot of experience. You may be familiar, especially if you're an orthopedic surgeon, that maybe 25 years ago, there was problems with how the ultra-high molecular weight polyethylene was cross-linked, and in some cases how it was post-manufacture sterilized, such that it produced particles that were just the right size that macrophages could ingest them, and the macrophages would die and release lysozymes, and it would dissolve the bone. It was a horrible complication for artificial hips and knees. Fortunately, with the Prodisc, that we learned from those mistakes, and we've never had, in 35 years of experience now, any osteolysis in the spine. Now, there are other implants on the market that you may be familiar with in the cervical spine that have been pulled from the market recently because they were producing osteolysis. And having a femur that you have to replace is because of osteolysis and structural instability is one thing, but replacing a whole vertebral body, it's a disastrous complication. It's never happened in 35 years. And so those are the materials that we use for the Prodisc. I can tell you that about 2/3 of the operation is regaining the motion of a diseased segment. And we have a saying that you, surgeons, are the motion creation device. And this then becomes the motion preservation device. In other words, if you put this into a vertebral segment that has not been properly mobilized, you won't magically get the motion after surgery. You have to recreate the motion in surgery. In one of my cases that I'll present in the Crossfire, it'll show you someone's absolutely bone on bone at L5S1, completely bone on bone. And remobilize that to 14 millimeters to recreate the motion, and then this is the motion preservation device. So about 2/3 of the surgery is those releases. And the releases consist of taking out the ALL or making flaps of the ALL is what we typically do, but you cut the ALL, taking out the disc, and then releasing the PLL in the canal off its attachments to the posterior vertebral body. And then if you still don't have the motion that you need, and this is a 10 millimeter device, which is most common height, it goes to about 12 millimeters in full flexion posteriorly. And so I look for releases, and I have a video in my talk that you'll see. I look for releases of about 14 millimeters. You can judge exactly how many millimeters you've released because these spreaders that we use to help us with the decompression, each of these blades is 3 millimeters. And so you can tell very quickly that there's 3 and 3 and 6 in the middle, so that's a release of 12. And so you can calibrate your eyeball very carefully off of these blades and get that approximately 14 millimeters of release, so that when you put in the device, you will be able to take advantage of all the motion of the device. And so that's about 2/3 of the surgery. So anyway, going back to the releases, you release the PLL off its attachments. If you don't have the height that you need posteriorly without fish mounting, you want the segment to do this. You don't want it to do this. You don't want the fish mount and be tight posteriorly. If you don't have the releases, then we take out the entire posterior longitudinal ligament from the front of the spine. Now, people that haven't been trained to do that look like you have two heads. You're like, how can you take out the PLL? The dura is right behind it. But we do it all the time in the cervical spine, right? All of us take out the PLL in the cervical spine, or at least are trained to do so. And it's the same thing in the lumbar spine. It's just a big cervical spine. I have very good vision. I get tested each year as part of the military. I have 20/15 near vision, and so I just do it under my direct vision. But you can use a microscope if you want to, and you basically go in laterally in the reverse trajectory of Camden's triangle, and then you start taking the PLL out. If I'm chasing a recurrent disc herniation, I start on the virgin side and then work across to the disease side so that I can make sure that I'm releasing any adhesions of the dura to the PLL. And I've probably take out the entire PLL in about 1/3 of my cases. And I knock on wood, I've never had a dura leak, and I've done like 500 lumbar discs. Easily 500 lumbar discs, probably more. The last set of releases, so it's ALL, disc, release the PLL, take the PLL, and then the last release is starting in the posterior lateral quarters and coming forward to take out some of the lateral annulus posteriorly. You have to be careful how much you come up because the exited nerve root from the level above is crossing the disc space there, so you don't want to get the nerve as it's blending into the lumbosacral plexus. But you go ahead and you can release about 1/3 of that posteriorly. And I stop, in that sequence of releases, I stop at any time that I have the release that I want. And so you get the releases. And these are the spreaders that help you do that. And then once you have your releases, you check and make sure that the release is balanced from side to side. And I don't know if the camera will show this or not. Maybe you can get in here. But you check your release and make sure, I don't know if that camera shows up, that the motion is there. Can you look straight down on top? Just come over my hands here. Even more, yeah. Can you see there a little bit? It's pretty bright that there's actually motion in this segment. And we check one side and make sure that one side is not too tight. And then we move the distractor to the other side and we check the other side and make sure that we have a balanced release side to side. And again, that's about 2/3 of the surgery is getting the releases. The last third is very simple, which is actually putting in the device. What size is this, do you know? Can you get me the trial for this size? No, you can leave it on, but no, No, you can. I just need to know what size this is. Thank you. And you can put this back on. Thank you. So then the next step is to trial. There's no up or down on the trial. You can be up this way or this way. We have this mallet in the set, and this goes into the disc space. Now understand, you've already done all your releases, and so you know that you have motion in that segment. And then this goes in, and you take a lateral x-ray and make sure that you're all the way back. If you need to go further back, because there is a safety stop right here, it's called anterior referencing, so we're referencing off the anterior vertebral body, and you place this in, and you have a long screwdriver, and if you are anterior referencing, that's a screwdriver. Yes. If you're not far enough back with your trial, because you want to go all the way to the posterior vertebral line. And the reason why is that's where the apophyseal ring, the growth ring for the vertebral body is, very hard bone, and you want to set this disc on very hard bone. If you set it on the cancellous bone, number one, your center of rotation could be off, and number two is it's the softer bone, and so the disc could subside. And so you want to get all the way line to line to the posterior apophyseal ring. And so to help you do that, you can use this screwdriver and back this safety stop off. And each one 360-degree turn is a millimeter to back it off. You can see I'm backing it off, making the height between here and here taller. And so you use that safety stop to help you get all the way under the posterior apophyseal ring. Once you're in good position on the lateral x-ray, then you come up to an AP and you check your placement left and right, and then you also check your rotation. Now I will tell you that this disc is designed as what's called a semi-constrained device. Semi-constrained means that the mechanical stops are just supra-physiologic, just above what the physiological limits of the spine are. And so it is semi-constrained. It is not constrained in rotation. So rotation is the most forgiving, but you check your lateral x-ray, then you come up to an AP, and once you're happy, you take it back to the lateral position and you make your keel cut in the bone. And so you've already proven that you have good positioning, and this slides right down the trial. Obviously, the prosthesis will end up being exactly where your trial is, and so, sorry, the model here is fighting me a little bit. The prosthesis will end up being exactly where the trial is. And so make sure that your trial is perfect as far as depth and centering left and right and rotation. And then once you have this perfect, then you go ahead and make your keel cuts. We do this under lateral x-ray. Sometimes at L5S1, because of the lordosis of that segment, your superior, your cranial keel cut will not be quite deep enough, and so you have to make an additional keel cut. So you back this out about a third of the way or so. You don't back it out all the way because you never want to make a parallel keel cut next to the one you already made, because you will lose your primary fixation. But you have to make your cranial keel cut, and then you cephalize your hand like this, and then you make your keel cut on L5 a little bit deeper. That's really common to have to do that. So now the keel cut is made, and it's time for insertion of the device. You have a nice slap hammer here. The instrumentation comes in just these trays here. It's a very simple system. When Dr. Marnay started putting in discs again in 1999, He collaborated with Rudi Bertagnolli, that you may know out of Straubing, Germany. And I like to think that that it was the German influence from Dr. Bertagnolli that led to a very streamlined set where it's very simple. So now we've made our keel cuts, and it's time to put in the device. The single armature goes cranial. The dual armature goes caudal. So there is an up and down to this. And this goes into the keel cut here. That I have made. I'm going to remove this because it's a little bit in the way. This goes into the keel cut, and then you hammer this down. And once it's in good position on the lateral x-ray, then it is time to distract across the disc space. And this is the inserter distractor. And what this does is it separates the end plates such that we can fit our polyethylene liner in. So this is 3 pieces that turn into 1 piece. And so this goes all the way down like this. And if you could see it on x-ray, it goes all the way down. If you can see it on x-ray, the end plates are coming apart like this. They're not fish mouthing because you've done the proper releases posteriorly. They're doing this, and now it has enough room to place the polyethylene liner down the rails. We have a couple of mantras in our surgical technique, and that I actually put into my surgical dictation. And one of the mantras is dome up, dome up. So if you look here, this is a flat end here, but this is a dome. And obviously this is a dome as well. And so dome up towards the patient's head and dome up towards the ceiling. And this comes in here like this. Oh, there we go. Okay. All right. Yes. Good. Okay. So this goes down. I was just a little out of sequence there on this. So the polyethylene liner goes down, dome up, and then this distracts those end plates, like we said. And then there's a final poly pusher that fully seats the polyethylene liner. Again, it's we can't zoom in with that camera. And this fully seats the polyethylene liner, and it is seated. Now this comes out. Tommy Bar can help you. And then the technique guys talks about wiggling this. I have found that the best way to take it out is with one hit of the slat hammer. Just like this, very atraumatic. And then the last step is we want to make sure that the polyethylene liner is fully locked into place. And so we check, and this is another one of our mantras, that the polyethylene liner to the metal end plate is no step, no gap. So there shouldn't be a step or a gap. And the patient now has a brand new artificial disc at L5S1, and they're going to love it. They're going to love it. So it's very simple. Again, 2/3 of the surgery is going to be getting the releases. You are the motion creation devices, and this is the motion preservation device.